Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is non-communicable diseases and mental health, prevention, screening, and management among PLHIV. And the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day, sir, is currently working as a technical specialist public health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Swetaji. So, good afternoon, everybody. Today's topic is non-communicable diseases and mental health, its prevention, screening, and management among PLHIV. And this is found in the National Guideline for HIV Care and Treatment 2021, chapter number 5.1. This topic has already been taken under National Distance Learning Seminar Series. And the last speaker was probably Dr. Manish from JHU. So today's discussion would be basically a recapitulation of what we have learned during those NDLS. Now, coming to the subject proper. Today's session, we will discuss about the background of the NCD, then individual diseases like hypertension, diabetes mellitus, cardiovascular diseases, mental health, and common cancer, their screening, diagnosis, and initial management in the ART centers. Now, this non-communicable diseases among PLHIV is very, very important nowadays because PLHIV is living longer with effective, safe antiretroviral drugs, and because of aging, they are also developing different NCDs, just like the general population. Now, to know a little bit about the NCD and its impact on the morbidity and mortality, the hypertension, cardiovascular diseases, renal disease, cancer, then respiratory diseases, diabetes mellitus, mental health disorders, all these accounted around 63% of global death. And similarly, the DALI, that is disability adjusted life year lost, was 80% for diabetes mellitus, and ischemic heart disease, it is 34% in the general population. And this NCD becomes more important for PLHIV because these PLHIVs are already in chronic immune activation, in a stage of chronic immune activation. Then there are different medications and their side effects, co-infections, infections, and also because of the aging. Now, these NCDs are caused by a combination of genetic, physiological, lifestyle, and environmental factors, just like in general population. It also has a role in the causation of NCDs in the PLHIV. Now, let us investigate some of the common non-communicable diseases. Like cardiovascular, we have hypertension, ischemic heart disease, stroke, rheumatic heart disease. In the respiratory system, we have asthma, COPD, occupational lung disease like pneumoconiosis, cystic fibrosis, pulmonary hypertension. And in the endocrine system, we have diabetes and its different types, hypothyroidism, etc. And then renal, we have chronic renal disease. And in the central nervous system of the psychiatric disorder, we have depression, anxiety, schizophrenia, mood disorder, etc. And in blood, we have anemia, hemoglobinopathies. And among cancer, we have breast cancer, cervical cancer, lung cancer, oral cancer, prostate cancer, colon and stomach cancer, leukemias, lymphoma. And in the musculoskeletal system, we have arthritis. So these are the examples of common non-communicable diseases in the PLHIV. Now, how do we prevent the formation of NCDs in the PLHIV? So the best method is, the ideal situation is where we'll do health promotion, that is primordial prevention. Before the patient developed a disease, we try to prevent the disease by lifestyle modifications, healthy living, and proper balanced diet, exercise, etc., which we will see later on in the subsequent slides. And screening for early detection. Now, if we fail to prevent NCD development by health promotion, then we need to screen the disease as early as possible. And once we screen it, and if we find that possibly the patient is having the disease, then we need to diagnose them as per the established criteria. And once it is diagnosed, then we manage, including lifestyle changes and pharmacological therapy. And once we start a patient on treatment, that is management, then we need to follow up with the patient regularly to see whether the treatment goal is achieved or not, whether the patient is adherent to medication and the different advices, whether he is following the lifestyle changes. And to look for side effects of drug and drug-drug interactions. So if we look at this pyramid, we see that it is best to prevent the development of NCD by proper health promotion. Now, health promotion is a combination of basically physical activity. That is, at least 150 minutes per week, we should go for moderate level of physical activity. And we can also practice yoga and meditation. And weight control, that is BMI, should be maintained within 18.5 to less than 23. And all individuals who are overweight should go for a low-calorie diet and dynamic physical activity. And for diet, we should take balanced diet with whole grains, vegetables, fruits, and pulses. And that should be as per the locally available items. We need not purchase and buy costly items for diet. Whatever locally available, from there we can prepare a balanced diet. And we should restrict our blood salt intake to less than 5 grams per day. That is less than 1 teaspoonful. And we should also limit the sugar, fatty meat, and dairy fat, and the fried food. Then we should stop all forms of addictions, especially tobacco and alcohol. And those people who are not a smoker or not a alcohol abuser, so we should advise them and counsel them not to start smoking or taking alcohol. And whoever is taking alcohol, then we should advise them to at least, if possible, to give up alcohol or to limit excess of drinking. It should be in moderation. Now, then adherence to treatment. We should explain the patient the dose and how frequently he has to take particular medicine and how to take care with ARVs along with additional medications. So, for example, whoever is working in the ART center, they know that for dolutegravir, even if the patient is suffering from anemia, we cannot co-administer iron supplements with the dolutegravir at the same time. At least there should be a gap of 6 hours. So that things we need to explain the patient, and we also explain to the patient the possible side effects and drug-drug interactions that are possible with that particular medication, so that they do not become panic if such a symptom or drug reaction appears at home. And we should counsel them to contact the ART center or the nearest health facility at the earliest if such a side effect or adverse drug reaction is experienced at home. Now, coming to the specific NCDs like hypertension, is screening, diagnosis, and initial management of PLHIV, adult PLHIV in the ART center. So the current guideline recommends that all PLHIV above the age of 18 years should undergo screening by healthcare providers through the measurement of blood pressure with standard equipments, once at registration into HIV care or during ART initiation, and thereafter every 6 months after ART initiation. And if the patient clinically, if the treating doctor finds it clinically relevant to measure the blood pressure, he can repeat it at any time. So, or if the the PLHIV demands for a request for a BP measurement, then we should provide them. We should measure the BP. Then diagnosis of hypertension is done by 2 measurements at 2 visits, at least separated by 1 to 4 weeks. If the patient is having is found to have systolic blood pressure of more than 140 in 2 occasions, and systolic diastolic blood pressure of more than 90 millimeter Hg in 2 occasions, then we can label him as having hypertension, and we should implement lifestyle modification and other treatment as per the guideline. Now, hypertension, where systolic blood pressure is more than 180 or diastolic blood pressure is more than 110, we call it as a hypertensive urgencies, where there is no evidence of target organ damage. And in emergencies, where systolic blood pressure is more than 180 and diastolic blood pressure is more than 110 to 120 millimeter of mercury, and is associated with target organ damage in the form of, say, cardiovascular or cerebral or renal damage or grade 3 to grade 4 retinopathy, we label them as hypertensive emergencies. These hypertensive urgencies and emergencies should be referred to appropriate department immediately. Now, diagnosis of hypertension in PLHIV. Other investigations that we can do is fasting blood sugar, because it is seen that hypertension and diabetes frequently coexist, and many of and diabetes is also a cause of hypertension. So we . then urinalysis for possible proteinuria if the patient is having diabetic nephropathy. And also the presence of this proteinuria is a high risk marker for cardiovascular morbidity and mortality. Now, the desirable for PLHIV, the desirable investigation for PLHIV is systolic blood pressure of more than equal to 160 millimeter of mercury, or diastolic blood pressure of more than equal to 100 millimeter of mercury is lipid profile to know whether the patient has a cardiovascular diseases, and serum creatinine, sodium potassium assessment for renal impairment, and ECG for the evaluation of target organ damage in the form of left ventricular hypertrophy. All these are possible with hypertension. So we need to screen for this along with the management of hypertension. Now, target for BP control in a PLHIV less than 80 years of age is systolic pressure of less than 140 and diastolic blood pressure of less than 90. But for patient above 80 years of age or older, it is systolic less than 150 millimeter of mercury, while diastolic is less than 90 millimeter of mercury. But in all forms of hypertension, all patients should be encouraged to restrict their salt intake to 5 to 6 grams per day. They should be put on low-fat diet. They should follow regular exercise, and weight should be maintained with a BMI of 18.5 to less than 23 kg per meter square, and along with cessation of smoking, alcohol, and other addictions, if any. Antihypertensive therapy for uncomplicated hypertension are different classes of antihypertensive, like angiotensin converting enzyme inhibitor like enalapril, angiotensin receptor blocker like losartan, calcium channel blocker like amlodipine, thiazide diuretic like hydrochlorothiazide, and beta blockers like atenolol. These are the examples of some of the members. But each category has got different members. These are some of the examples only. Now, for the management of hypertension, if it is a grade 1, that is systolic blood pressure of 140 to less than 160 millimeter of mercury, and a diastolic blood pressure of 90 to less than 100 millimeter of mercury, we call it as grade 1 hypertension. And the recommendation is lifestyle modification over 3 months. Now, if over 3 months, lifestyle modification can bring down the blood pressure level below 140 systolic and below 90 millimeter Hg of diastolic pressure, then we will continue with lifestyle modification. But even after 3 months of lifestyle modification, if the target BP is not achieved, then we should add one drug pharmacotherapy and we should continue lifestyle modification. Lifestyle modification. And in case of grade 2 hypertension, that is a systolic blood pressure of 160 to less than 180 and millimeter of mercury, and a diastolic blood pressure of 100 to less than 110 millimeter of mercury, we should straightaway start one drug pharmacotherapy along with lifestyle modification. And for grade 3 hypertension, that is hypertensive emergencies and urgencies, where systolic blood pressure is more than equal to 180 millimeter of mercury and diastolic blood pressure is more than equal to 110 millimeter of mercury, we should go for dual drug therapy with a lifestyle modification. And we also need to refer the case appropriately to the appropriate department in time, which we will see later on. Now, the dose of drugs that can be increased or new drug can be added approximately 2 to 4 weeks interval. However, this interval is arbitrary. I mean, depending on a particular case, it can be earlier also. Patients with diabetes mellitus should be initiated on drug treatment when systolic blood pressure is more than 140 millimeter, and the target for blood control should be a systolic blood pressure of less than 140 and diastolic blood pressure of less than 90. Out of all those different groups of antihypertensive, AC inhibitors are preferred as initial therapy, and calcium channel blocker and diuretics may be used as add-on therapy if we fail to achieve the target therapeutic goal with AC inhibitor. Then we add on either beta blockers or calcium channel blockers or diuretics. Or in special cases, we can also go for beta blockers, particularly when the patient is having, say, tachycardia or there is thyrotoxicosis, then beta blockers would be a preferred drug. While in a younger individual, AC inhibitors is a preferred drug. while in elderly, calcium channel blocker is also a preferred drug. So we case-to-case basis, we need to select a particular antihypertensive drug for the management of hypertension. AC inhibitors and thiazide diuretic do not have any interaction with ARB, so we can safely administer them in PLHIV. However, there are some potential interactions between beta blockers and calcium channel blocker. If these are co-administered in presence of PI, then there is increase in the calcium channel blocker and beta blocker blood level. So we may have to titrate the dose. While in the presence of NNRTIs, their blood level may go down. So we again will have to adjust the antihypertensive dose. However, the drug levels of ARBs are not affected by calcium channel blocker or beta blockers, and there is no need for dose adjustment of antiretroviral drugs. If we prescribe beta blocker in presence of PI, then we need to be cautious for QT prolongation because both the drug prolongs the QT interval, and we need to monitor ECG to exclude any QT prolongation with the co-administration of PI and calcium channel beta blocker. Now, along with this treatment, we need to screen, diagnose, and treat uncomplicated hypertension by a trained medical officer, and this management can be given in the ART center itself. However, in case of grade 3 hypertension, that is hypertensive emergencies and hypertensive urgencies, or in those cases where there is failure to achieve treatment goal, that is systolic pressure of less than 140 and diastolic blood pressure of less than 90 millimeter of mercury, in those, even after using 2 antihypertensive medicines to the maximum dose, then we need to refer these cases to a physician who is experienced in the management of hypertension. And in case of hypertensive emergencies and urgencies, we immediately should refer the patient to appropriate facility, and provider shall be done in case of hypertensive urgencies and emergencies. Now, coming to diabetes mellitus screening, diagnosis, and initiation of initial management of PLHIV in the ART center. All PLHIV should undergo screening through random blood sugar test at registration into HIV care or during ART initiation, and 1 to 2 months after initiation of ART, and then at every 6 months. Or during any change of regimen, whether it is a substitution or a switch, we can repeat a random blood sugar level, or separately as a screening examination if requested by the person or if the treating clinician find it important on the basis of clinical findings. Now, screening of diabetes mellitus, the symptoms that we look for are polyuria, polydipsia, polyphagia, weight loss, tiredness, weakness, generalized pruritus, recurrent urogenital infection, delayed healing of wounds. Out of all this generalized pruritus is probably missed quite often, but this is very, very important sign of diabetes, and this happens mostly on the outer side of the thigh and outer side of the arm, back in the scapular region. These itchings are there. Now, diagnostic criteria for diabetes is compatible symptoms of diabetes plus casual or random blood sugar level of more than equal to 200 milligram per DL, or a fasting blood glucose of more than equal to 126 milligram per DL, or GTT, that is glucose tolerance test, 2 hours after ingestion of 75 gram of glucose if the RVS is more than equal to 200 milligram per DL, or if the glycosylated hemoglobin is more than equal to 6.5%, then we presume it to be a diabetes. And diabetes diagnosed using any of these criteria should be confirmed with another test subsequently. Say, for example, we found in a case of PLHIV, the glycosylated hemoglobin is 8%. Now, this shows the patient is having diabetes, but we need to confirm it with either fasting blood glucose level or 2-hour PP blood sugar level. Now, blood glucose fasting monitoring of diabetes is to be done. Fasting blood sugar and 2-hour postprandial blood sugar at least once a month, and more often if the values are not in the ideal target range. Even if after management the blood sugar level are not within the target range, then we can repeat fasting and PP blood sugar more frequently. And hemoglobin, glycosylated hemoglobin, at least 6 to 12 months if available, and more often, that is every 3 months if values are not in the ideal target range. Clinical examination need to be done during every visit, and minimum every 3 months we need to examine the patient for possible complications like retinopathy, nephropathy, neuropathy, peripheral vascular diseases, coronary artery disease, at least once in 6 months. At least once in 6 months. Now we need to also optimize the weight so that the BMI is within 18.5 to less than 23 kg per meter square, and waist circumference in case of man, it should be less than 102 centimeter, while in case of woman, it should be less than 88 centimeter. Blood pressure, we know it has to be less than 140 of systolic and less than 90 millimeter of mercury in case of diastolic, and lipids should be within the normal range. Routine examination of food to be done during every visit, and education regarding food care to be given to all patients at each visit, whoever is having diabetes. And we should also discourage tobacco use and excessive use of. Now, the other investigations that we can do based on the availability are lipid profile, serum creatinine, urine analysis for proteinuria. Now, this proteinuria can be a macroproteinuria or a microproteinuria. So while giving requisition, we might it might be a good practice to mention urine analysis for microalbuminuria, particularly in the early part of the disease. Now, the management of diabetes in adult PLHIV, the national guideline says for patients with pre-diabetes, that is abnormal result but do not meet criteria for diabetes, we should monitor fasting blood sugar level or HbA1c level if available every 6 months, and we should encourage lifestyle modification as per recommendation. Now, lifestyle modification, as mentioned under health promotion, is recommended for all PLHIV with diabetes for life, for the whole life, and it is also for hypertension. Anybody who is having hypertension should also follow this lifestyle modification for the rest of his life. If target blood glucose is not achieved, even after lifestyle modification over 3 to 6 months, then oral hypoglycemic should be added. So the preferred oral hypoglycemic is metformin for type 2 diabetes mellitus. And we should titrate the metformin to a target dose glucose value of fasting 126 milligram per DL or HbA1c less than 6.5% if available. Now, sulfonylureas may be given to patients who have contraindication to metformin, or if metformin doesn't improve glycemic control. Patients with diabetes mellitus are at increased risk of developing TB. This is a common experience that even in the general population, if the person is having uncontrolled diabetes, they are susceptible for development of tuberculosis. And similarly, in PLHIV also, they are susceptible to development of tuberculosis if their diabetes is uncontrolled. Now, metformin doesn't have any interaction with the metformin should be used with caution in PLHIV with renal insufficiency, liver disease, and active infection, including tuberculosis, and those with wasting or congestive cardiac failure due to the risk of lactic acidosis induced by metformin. A dose adjustment of metformin is recommended if the patient is on DTG-based regimen, and we should limit the daily dose to a maximum of 1,000 milligram per day when co-administered with dolutegravir. And renal function monitoring, blood glucose monitoring is recommended when metformin and dolutegravir are co-administered, because we know that dolutegravir can give rise to weight gain and hyperglycemia. Though more evidence need to be gathered before saying it with confidence. And NRTIs and PIs may cause increase or decrease in the level of sulfonylureas, which may require dose adjustment of the sulfonylurea. And the dose adjustment may be done on the basis of blood glucose level found on monitoring. Here and other referrals. Screening, diagnosis, and management through lifestyle modification can be provided by a trained medical officer in the ART center. However, initiation of oral hypoglycemic agents should be done by a physician, and continuation of treatment can be provided by trained medical officer in PLHIV with controlled diabetes. Once the patient is referred to a physician experienced in the management of diabetes, and once after control of diabetes within the target of target is fasting blood sugar less than 126, then such a patient can be monitored in the ART center by the trained medical officer. Management and follow-up by physician are recommended in those patients who, despite of metformin and other hypoglycemic, their hyperglycemia is not controlled, then those patients need to be followed up by the physician experienced in the treatment of diabetes. And patients with food ulcers and patients with vision impairments, that is nephropathy, retinopathy, etc., need a proper referral to the concerned departments, and they should follow the cases there. Now, coming to cardiovascular risk factors, is their screening, assessment, and initial management for adult PLHIV. We know well that hypertension, diabetes, dyslipidemia, these are all risk factors for development of cardiovascular diseases. Obesity, BMI of more than 30 kg per meter square, increased waist circumference for men more than 102 centimeter, and for women 88 centimeter. Physical inactivity, tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, and family history of cardiovascular disease. All these are the risk factors for development of cardiovascular disease in the PLHIV. Now, assessment is done at the time of registration in HIV care or during ART initiation, and then at 3 months and 6 months of ART, and should be repeated every 6 months thereafter. Now, in the history, we need to ask for heart disease, stroke, diabetes, or hypertension, or any treatment of those diseases in the PLHIV, any angina, breathlessness on exertion or on lying flat, numbness or weakness of limbs, loss of weight, increased thrust, polyuria, then puffiness of face, swelling of feet, passing blood in urine, then any past or present treatment or medication, current or past tobacco use or alcohol consumption, lifestyle, whether it is sedentary or active, and if there is any premature heart disease or stroke in the first degree relative. Now, after this history taking, we should assess BMI and waist circumference. We should also measure blood pressure, signs and symptoms of diabetes. And we also should look for pitting edema, heart murmur, basal crepitation in lung, tenderness in abdomen, particularly right hypogastrium. If we find a tender hepatomegaly, which may be a sign of heart failure, then repeat profile if available. Now, management for all PLHIV with history of angina, then shortness of breath, numbness or weakness of limb, loss of weight, increased thrust, polyuria, puffiness of face, swelling of feet, passing blood in urine, pitting edema, heart murmur, basal crepitation in lung, and tenderness in abdomen, we should refer the case appropriately. Now, we should advise and counsel the patient to follow lifestyle modification, which is mentioned under the health promotion in the previous slides. And treatment with statin is recommended for patients with established cardiovascular diseases and for patients with dyslipidemia. However, in presence of PI and efavirenz, we will try to substitute the drug to lipid-friendly drugs if possible. If not possible, then we should administer atorvastatin. Starting dose is 10 milligram per day, and gradually escalating to maximum dose of 20 milligram per day if the patient is on PI. However, in the absence of PI, the maximum dose would be 80 milligram per day. Simvastatin and lovastatin are contraindicated in the presence of PLHIV on protease inhibitor. Now, coming to mental health among PLHIV. PLHIVs are more prone for psychological ailments due to HIV per se, because of the disease process itself, because it affects the brain and nerves of the body, and as well as due to opinions and experiences regarding HIV in their surrounding, the stigma, discrimination, and all these things. PLHIV may face multiple types of psychological issues like depression, anxiety, internalized stigma, etc. Any such issue can significantly hamper adherence and mental well-being. Depression is 2 to 3 times more prevalent in PLHIV than in the general population. Why these are important? Because of the disease, they may also commit suicide and all. But a person who is depressed, for him, life has no meaning. Was the use of antiretroviral drugs and visiting the ART center regularly in time. So they tend to falter in those two aspects. That is, their adherence goes down, and their visit to the ART center is also gets impaired in the presence of depression. So we need to pick them up as early as possible so that they adhere to the treatment. Now, for screening, there are 2 questions. If answer to any of the question is yes, then we should administer PHQ-9, that is Patient Health Questionnaire 9, and that these questions are asked when the patient is registered in the ART services or during initiation of ART, and thereafter every 6 months 6 months, we should ask these questions. The first is, during the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? And the second question is, during the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? If the answer is yes for any of the two questions, then we need to go for administering PHQ 9, that is Patient Health Questionnaire 9, which we'll see in the subsequent slides. So these questions are asked from 1 to 9, and the patient has to report based on the last 2 weeks. That is, if a patient is having no such complaint, then the grading would be 0. Now, if it is several days for the last 2 weeks, the grading is 1 for each of the symptoms. And if it is more than half the days over the last 2 weeks, then it is 2. And if it is nearly every day for the last 2 weeks, then the grading is 3. So the symptoms that we screen here are little interest or pleasure in doing things, feeling down or depressed or hopeless, trouble falling or staying asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you are a failure or have let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching television, moving or speaking so slowly that other people could have noticed, or the opposite, that is being so fidgety or restless that you have been moving around a lot more than usual. And if there is any thoughts of self-harm, there is thoughts that you would be better off dead or of hurting yourself in some way, then these 9 questions we ask, and based on their grading, we classify them as 0 to 4, that is depression is unlikely. So we'll go for repeat screening every 6 months. Now, if the grading is 5 to 9, then possibly the patient is having mild depression, and we should provide supportive counseling, and we will continue to monitor the patient more frequently, that is once a month, that is at every visit. If patient is on efavirenz, then we try to substitute efavirenz with other antiretrovirals that doesn't have any psychiatric side effects. It is known to all that this efavirenz is capable of producing psychiatric symptoms, so we try to substitute it if any patient is on efavirenz. But nowadays, this efavirenz is phased out, so there are little chance that the patient would be on efavirenz. Now, 10 to 14 score, we classify it as a moderate depression, and 15 to 19, it is moderate to severe depression, and 20 to 27, severe depression. In all these 3 categories, we should provide supportive counseling through trained counselor, and if the patient is on efavirenz, we'll substitute with another ARV, and we should refer the patient to psychiatrist for further assessment and antidepressant medication. The key supportive counseling messages that we need to give to PLHIV, whoever is having depression, are psychosocial support. That is, we need to explain the patient about depression and reassure that it can be managed. Feeling of hopelessness, worthlessness, negative emotions are part of depression and will revert back to normal with proper counseling and treatment. And we need to inform on the course of counseling and treatment, how often they need to come for counseling and how often they need to take the medications advised from by a psychiatrist, and how long it need to be continued. Then identify supportive family members and involve them as appropriate, because the patient is continuously under depression. So at home also he needs somebody who can take care of him at home. So accordingly, we'll identify such a supportive family member. And we also will try to involve peer and community support groups. Then we'll counsel on self-management skills, that is to continue ART as prescribed, identify activities that they use to find interesting and pleasurable, encourage participation in these activities. Even when the patient is depressed, we'll try to impress upon him that by getting involved in those activities which he enjoyed earlier, the depression will go off rapidly. Then get regular and sufficient sleep, that is approximately 7 to 8 hours. Physical activities to be increased, and contact with ARTC or healthcare facility immediately if there is any thought of self-harm. And then we try to reduce stress by identifying and trying to reduce stress points, identify and discuss stress increasing points such as health issues, family issues, relationship problem, gender-based or partner violence, finance problem of finance, stigma, discrimination. We need to address them individually from case to case basis, and identify and discuss problem-solving techniques. We need to suggest stress management such as meditation and relaxation techniques. There are different techniques which can be provided by a trained counselor or by a psychiatrist. Now, medical management of depression. Depression can be managed by a combination of medical and psychological interventions. Whenever needed, we should prescribe antidepressant, and it should be prescribed by a psychiatrist. Antidepressant treatment is generally given for 6 to 9 months, and those should start, the principle is that we should start very low with a very low dose, and we should increase it gradually, slowly. And for any increment in dose, we should wait for 2 to 4 weeks time, because this time is required for all the antidepressant to exert its maximum therapeutic effect. And antidepressant should not be stopped abruptly. Dose should be tapered gradually over a period. And there are 2 main classes of antidepressants that can be used safely in PLHIV. These are tricyclic antidepressant like amitriptyline and SSRI like fluoxetine. Though there are many other groups but which have many side effects, but these 2 groups are without having any much side effects, and hence it can be, a drug-drug interaction, etc., less with these 2 group of antidepressant. So that can be safely administered in the PLHIV who are on multiple prescriptions. There are no drug interaction between NRTI and an NRTI or integrase inhibitor and amitriptyline or fluoxetine, so we can safely use them. PI increases drug level of amitriptyline and fluoxetine, but there is no dose adjustment of amitriptyline or fluoxetine is needed. And amitriptyline and fluoxetine doesn't affect ARB drug levels, so we need not have to modify the ARB drug doses. Amitriptyline, while co-administered with PLHIV on PI, we need to be cautious about QT prolongation, because both the drugs are capable of prolonging QT interval, and hence ECG monitoring is recommended for all those patients who are put on amitriptyline plus protease inhibitor. Now, a few sentences regarding children and adolescents living with PLHIV. Mental health disorders during childhood and adolescence are defined as delays or disruptions in developing age-appropriate thinking, behavior, social skills, or regulation of emotion. And the prevalence is about 6% to 12%. And in the age group of 13 to 17 years, the prevalence is 7.3% in children and adolescents. And overall, we'll find around 8 to 13% of children are estimated to need mental health services. Some of the warning signs that might indicate presence of a mental health condition in children or adolescents are persistent sadness for 2 or more weeks, withdrawing from social interactions or avoiding social interactions, hurting oneself or talking about self-harm, talking about death or suicide, outburst or extreme irritability, out of control behavior that can be harmful, drastic changes in mood, behavior, or personality, changes in eating habits, loss of weight, difficulty falling asleep or maintaining sleep, frequent headache or stomachache, difficulty concentrating, changes in academic performance, and avoiding or missing school on different pretext. So any sudden change in children or adolescents should trigger our suspicion towards the development of any mental health condition. Now, coming to common cancers among PLHIV. We need to prevent cancer. We need to prevent cancer in PLHIV by advocating to stop tobacco use, and those who are not taking tobacco, we need to counsel them that they should not start taking tobacco or other addictions, and we should promote healthy dietary practices and physical activity. Now, some principles of management of cancer and the management of HIV in PLHIV is that those PLHIV who are receiving radiotherapy or surgical intervention should continue ART as before. But PLHIV who are receiving chemotherapy for the treatment of cancer, the treating oncologist and the treating physician should consider the potential drug interactions and toxicity profile, and might have to modify either the chemotherapy or the antiretroviral therapy or both. Now, for early detection of cancer, some of the warning signs that we need to advocate to the PLHIVs are to notice for any change in bile or bladder habit, and wound that doesn't heal, that is a chronic non-healing ulcers or something like that, then unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty swallowing, an obvious change in a wart or mole, nagging cough or hoarseness of voice. And we need to educate on self-examination and report for any unusual sign and symptoms. We need to examine all the patients for warning signs, and routine examination of oral cavity, breast, and cervix are to be done. And we need to refer a person with a suspicious lesion or sign and symptoms of possible malignancy. We need to refer them appropriately in time. Now, for cervical cancer screening, it should be done as per the national guideline. It should be done at ART initiation. Then we should repeat the screening every 3 years if there is, if the initial test is negative for any malignancy. And women who have been treated for cervical problems should receive follow-up screening at 1 year, or it can be done at any time based on the sign and symptoms and based on the decision of the treating physician. Method of screening is VIA. There is visual inspection with acetic acid, 3 to 5%. And the observations that are possible with VIA is normal squamous epithelium of vagina appears pink, while columnar epithelium of uterus appears red, and conditions like inflammation, benign or malignant growth. The epithelium contains a lot of cellular proteins because of increased nuclear activity, and there is dense white patch. And in those cases, we need to refer them to a gynecologist or lady medical officer wherever available, or to NCD clinic at CHC and district hospital for confirmation and further management. Breast cancer screening, the risk factors are reproductive and hormonal factors like older age at the first pregnancy, early menarche before 12, or late menopause after 55, and those who never had any children, or women who take menopausal hormone therapy, there is hormone replacement therapy for 5 years or more after menopause. They are the risk factors for the development of breast cancer. And other risk factors are that family history. Risk of breast cancer increases in women with a first-degree relative with breast cancer, and being obese after menopause, physical inactivity, alcohol intake. Now, breast cancer screening can be done based on the, and we need to make the PLHIV be aware about the self-screening. The first person to detect any lump in the breast is usually the woman herself. And we need to teach her how to look for the danger signs of breast cancer, like change in size, nipple that is pulled in or changed in position or shape, rash on or around the nipple, and discharge from one or both nipples, puckering or dimpling of skin or around the nipple, lump or thickening in the breast, constant pain in the breast or armpit. All these are the signs that might point to the fact that the patient is developing some cancer or has already developed some breast cancer. All women living with HIV more than 30 years of age should be screened with clinical breast examination at ART initiation, and to be repeated within 3 years if the initial test is negative, or any other time if there is any sign and symptoms suspicious of breast cancer. And the method is clinical breast examination. Both the breasts are visually inspected and palpated in different positions from all the sides. And we need to teach the patient how to do that. And observations, these are made are inspection. If there is any change in symmetry in breast shape and size, and skin changes, if there is any dimpling, retraction, ulcerations, the level of both nipples, whether they are in the same plane or there is some change, retraction of nipples or inverted nipples. And in palpation, any discharge, whether there is any discharge from the nipple or nipples, color of the discharge, swelling, lumps, consistency of the lump, swelling the armpit, axillary armpit, above the collarbone, supraclavicular area, and root of the neck. Then referrals, clinical breast examination if it is negative, if no sign and symptoms noticed, follow up as per the routine screening schedule, that is every 3 years. Now, clinical breast examination, if it is positive, then we need to refer the case to surgeon for further evaluation with the ultrasonography, biopsy, mammography, etc., and to institute proper management. For screening all oral cancer, the risk factor is tobacco chewing. and is the most important risk factor for development of oral cancer. So we should advocate them to give up tobacco, and those who do not take tobacco or betel nut betel nut, we should counsel them not to start taking them. And if there is any source of chronic trauma to the oral mucosa, say for example sharp tooth or ill-fitting denture, we need to advise them to change those or to go for dental care, so that those chronic traumas are removed. Then health promotion by adequate emphasis should be made on cessation of tobacco use in any form. Then screening frequency, all PLHIV more than 30 years of age should be screened as per the national guideline at ART initiation and within 3 years if the initial screening is negative, and at any other time based on the physical sign and symptoms. Method of screening is basically oral visual examination. An observation made is precancerous lesions or conditions are local or generalized disturbances that predispose to malignancy in a particular site are the leukoplakia, erythroplakia, then palatal changes associated with reverse smoking or bidi smoking, and then submucous fibrosis. And referrals, if any abnormality is noted, we need to refer the patient to ENT department for further evaluation, diagnosis, and management. Thank you. So if there is any question, you can please ask me.
Right, sir. I'll just check the chat box, sir. Any questions from the participants? Please feel free to unmute your mic. Any questions regarding this topic? Participants can type in the chat box as well. Sir, I don't think there are any questions. I'll quickly run the feedback form, sir.
Okay.
The feedback form is now visible on your screen, requesting all the participants to please attempt all the 4 questions.
Yeah, there is a question in the chat box. If patient is taking 3 times diabetic medication, then tablet dolutegravir should be given when? Now, I think it is a more of a theoretical question, because 3 times a day oral hypoglycemic is rarely found, number 1. Number 2, if at all the patient is on, say for example, patient is put on metformin, what's the use of giving this metformin 3 times a day when it can be given only after dinner? And so for example, the patient is on sulfonylurea also, the usual dose is once a day. So theoretically, if you say that there is a patient, PLHIV, who is on 3 different types of oral hypoglycemic, taking 3 times a day, then we'll have to go for the drug-drug interaction that are possible with the dolutegravir and that particular oral hypoglycemic. And based on a particular molecule, the drug-drug interaction would be different, and accordingly we'll adjust the dolutegravir.
So there's one more question in the chat box.
Differential diagnosis of CL larynx, sign of CL larynx. Yeah, hoarseness of breathing, hoarseness of voice, all these are is a unique symptom which might point to a diagnosis of laryngeal carcinoma. Then usually given for uncontrolled diabetes. Yeah, it can be given. Say, for example, you can safely give insulin, either a long-acting one or an ultra-rapid-acting one 3 times a day or more often, and which doesn't have any interaction with dolutegravir. So we need not have to think so much if it is a uncontrolled diabetes mellitus, because we will be going to insulin.
So there's one more, two more in fact. How much PPBS is important, and for patients complaining of muscle wasting, what to suggest?
For a diagnosis of diabetes mellitus, we know the postprandial blood sugar should be more than 200, more than equal to 200 milligram per DL as per the guideline. And for patients complaining of muscle wasting, yes, there are n number of causes of muscle wasting, starting from diabetes mellitus to HIV per se, to say thyrotoxicosis. So based on our clinical judgment, we need to zero down to possible differentials, and accordingly we need to investigate to know the cause of wasting.
So the next question in the chat box.
We need to continue ART if the patient is taking diabetic and radiotherapy. There is no contraindication for it, neither for co-administration of radiotherapy or anti-diabetic, as we discussed in today's session. Yes, amitriptyline is very, very useful in peripheral neuropathy, but we need to remember that anybody who is on PI-based medication, we need to be very cautious while administering amitriptyline for possible QT prolongation. And then the guiding principle is that we should start with as low as possible. Maybe 5 milligram of amitriptyline might be useful in those cases in a particular PLHIV.
Any more questions from the participants? Please feel free to unmute your mic as well. You can ask questions. So I don't think there are any more questions. Thank you so much for facilitating this session. Thank you to all the participants for patient listening. We'll end the session now. Thank you.